I think we can get started. Welcome, everyone. We are thrilled to have this as our opening panel for the Innovations in Food as Medicine Virtual Summit. I don't know about you all, but the move to virtual has given us the opportunity to really expand the audience that we're reaching. It also gives us an opportunity to not sit in our chairs and listen to folks for a long extended period of time. So having these panels over multiple days also gets us more active and moving around, and really being able to digest the information day to day. So excited to have you all here. We are starting with this initial panel, which I am so thrilled about. And I'm really excited to hear the conversation that happens around bringing it all together, really looking across the food system and the health system to think about how we think about food as medicine from the farm to the table to the clinic. So I am going to kick it. So I'm Sarah Lampe. I'm the president and CEO of Prime Health. We are facilitating getting these panels coming together and having conversations, and we'll continue to facilitate whatever conversations need to happen. And I will come back at the end to summarize, to kind of wrap us up and look into what's next for the next panel tomorrow. But for now, I'm going to kick it over to Kevin Riddleberger, who is our moderator today, and he will introduce our panels and get us started. So over to you, Kevin.
All right.
Really quick. The chat is open to anybody who is in any of our guests, any of our attendees. Please use the chat to ask your questions, anything that you might want to have in there. We will curate and look at, and at the end, if we have time, we'll get to some of those questions. But everyone else we are not going to ask people to speak up. We're going to have the panel really be the voices of the conversation today. But if you do have any questions, please put them in the chat. All right, now to you, Kevin.
All right. Thank you, Sarah. I'm super pumped about this panel. I think it's going to be a lot of fun to hear all of these different voices and what they represent within the food is medicine ecosystem. And I think it's very relevant, and it's going to be a unique conversation that I don't have ever seen, come together from a panel, standpoint, to be able to really look at the intersection of healthcare, nutrition, and how food is locally sourced. Too often we talk about food systems and culinary preparation and clinical care in silos, and we treat farming as our agricultural, development, meal programs as logistics and convenience, and patient nutrition and chronic disease management as really an afterthought. But reality is that these things are so interconnected relative to food, where food is coming from, how it's prepared, and how we engage and change patient behaviors, where they're all essential for this to really make work from a food as medicine perspective. So, the panelists represent every stage of that journey, from growing food to preparing the food to treating patients. And so really excited to hear all of them and how they represent each other, and how we can learn more about how we can do this, together and not in silos. So let's get into it. And I want to be able to, thank the panelists for taking the time, today. And we'll kick off by each one of them giving a little bit of a overview of themselves, where their organizations engage in food as medicine and the ecosystem, how each of the panelists define the relationship between food systems and human health, and then probably most importantly, their personal why. What's really inspired them to be able to enter this space and to be able to commit and dedicate themselves, to this space. So we'll just kind of randomly go through the panelists, and then we'll dig into some of the questions. So let's start with Carrie.
Hi, everyone. I'm Carrie Cow. I'm the CEO and founder of RenewRx. I am also a seasoned clinician and medical provider. I've worked in family medicine for over a decade with mostly uninsured, underinsured, primarily Spanish-speaking population, initially starting in the clinic and transitioning to doing a lot of home visits for patients. And for me, I think what I saw was a couple things. One, I could either stay on time and kind of just say, eat healthy and exercise to my patients, or I could sit there and really try to explain kind of what's going on, draw on the exam table, things like that. But ultimately, my biggest challenge was that as a provider, I wanted to work with the patient to ultimately determine where they needed to go. But it wasn't actually until my home visits that I really had the eye-opening experience that ultimately it's not about the destination, it's about giving a patient a roadmap to really getting there and how to execute on these different things that we're telling them. And that's where I found the biggest barrier lies. Then COVID hit and I was furloughed because I couldn't do home visits anymore. So I went back to school and became a professionally trained chef with a nutritional focus and wanted to find a way to integrate culinary medicine into into my practice as well as into medicine in general. And really found that the biggest pain point for both patients and providers is patients with gestational diabetes is where we're starting. My sister, when she was diagnosed, she is a very, put together person where she calls you and she's got, you call her for all the answers. And when she called me crying because now suddenly she has twice the number of doctor's appointments, has to change her nutrition overnight, has significant risks to her and baby, and also has to poke her finger 4 times a day, she felt so helpless. And for me as a clinician who cares for these patients, I felt really sad because I didn't actually have the tools to really support her. And that's why we created the company Renew RX with the idea of really renewing the joy of pregnancy for patients and their care teams when they're diagnosed with a high-risk pregnancy. And I also want to make sure I save enough time for everyone else. So I'm happy to go into more about the company, but I can also pass the torch.
Awesome. Yeah, I think that resonates in terms of your sister's, journey and how it's so critical for each one of these, components that we'll talk about. And that's just one patient journey,
One of many.
and what's going on there. So, all right, let's go with Matthew.
Thank you, Kevin. Thank you, Carrie. Hey, my name is Matt Chandra. I am the co-founder and CEO of Tokabe. We started in 2008 as a single restaurant in Northside Denver, focusing on bringing access to native food rooted in the community. As we grew, we saw that the relationship with native producers and the food system was disconnected. And so we looked at how can we build a food supply chain, right, within the native system of keeping money within the communities that we represent. And so, Tokabe has grown over the years as a national platform to really source native and indigenous foods and distribute it throughout the United States. And really focusing on the ranchers, producers, caretakers, people of the water, and how do we deliver food to those communities. What really brought us into that intersection of food is medicine is when working in these communities, we saw that the health disparities that were diet related were significant. And we saw that the systems that are currently in place in a lot of these urban reservation communities and rural communities across the US aren't really identifying what does it mean to have culturally relevant food, indigenous foodways that are producing those foods, and looking at how we keep that money within the community. And so that's where we became involved with food as medicine from our experience of producing food over the last 17 years.
Awesome. Roberto?
Thank you, Kevin. Hi, everyone. My name is Roberto Mesa. I'm a first-generation farmer and CEO of Hardy Provisions. We connect local farms and producers across the Mountain West to institutions, including schools, clinics, restaurants. We work with a lot of food access organizations and food service companies, and we're trying to really scale a local food supply chain that is aligned on mission and values and stewardship. My farm, Emerald Gardens, is a year-round regenerative farm. We also use controlled environment agriculture, such as greenhouses and shipping containers to grow microgreens and mushrooms year round. And most recently, co-founded the Ag and Food Lab with a few other colleagues and collaborators. And that's our nonprofit to strengthen capacity across the community for local farms and food businesses by providing wraparound ecosystem services and eliminating barriers to entry. I came into this work soon after I took a leave of absence during my graduate studies at MIT. I was pursuing a degree in arts and culture and technology and experienced a lot of personal health issues that I think prompted me to really look at food as a way to heal myself. The more I read about nutrition and dietary changes and different lifestyle changes that I needed to make, the more that I was drawn to how plants actually grow. And so about 6 months after that, I interned with a local farm in Ohio where I was staying with my parents. And as soon as I got my hands in the soil and started working outside and eating the things that I was growing, I had a renewed sense of purpose, a renewed experience of my own health and well-being. And I knew that that was something that I wanted to dedicate my life to. So that added another layer to my view as a steward of my community, as a role that I could take and shape in agriculture. And it wasn't until 2020, during the pandemic, that I really began to see a lot of inequities in the food system as it's been designed, where there's a lot of gaps in getting food to people. So when I began to think about food as medicine, I said, of course it is. It was my medicine. But how do we get food to people in a way that's efficient, that's equitable, and that can be rooted within the community kind of sense of resilience and connection? So for me, food is certainly medicine. It's also culture, it's identity, it's resilience, and it's a tool for healing people and the land. But most importantly, it's a basic human right. And that's really what drives my partnership developments with institutions, and the creative ecosystem of farm, hub, and nonprofit that I think can yield visions of what our food system can look like in the future.
That's awesome. It's inspiring, as over the last couple of weeks, I've been preparing soil in my backyard, for my uh, garden, and just getting into the soil and getting excited about being able to go out and pick my food and be able to eat it and feed my family. It's like I love this time of year, and I just wish I had the ability to do it all year round. But I'm just not there yet as a farmer, to be able to do that. So, all right, let's round it out with Carlin. I think you're on.
Okay. That is my MO. I always forget to unmute myself. I am Carlin Fitzgerald. I'm a registered dietitian, and currently the Farm to School project lead with Aurora Public Schools Nutrition Services. I have been in school nutrition for about 12 years. My specific role is to bring more locally grown, raised foods to our students. Really bring some more like kind of agriculture, food systems, education, so that they can learn where their food comes from. A lot of students don't have that connection, and that's part of my role and part of my goals. In general, school nutrition is kind of a preventative and education type of piece, I guess, to the food as medicine. Really, our mission is to serve as many nutritious meals as we can every day to our hungry students. We see this in all districts, but especially Aurora is lower socioeconomic status. And so we do see kids that are experiencing quite a bit of food hunger, food insecurity and hunger at home. And so that's, our role is to make sure that those kids are getting the nutrition that they need, to grow and to be healthy and to thrive. School nutrition, I feel like, is often viewed as a support service to education, which we certainly are. But even more than that, I feel like our role is support to our students and our families. We help support their healthy growth and development and alleviate some of that food insecurity they may be feeling at home. And really just to make sure our kids can focus on learning instead of focusing on their hunger. Additionally, we try to kind of instill some healthy eating habits in our students, and really in supporting kind of the mental health piece of, lunchtime is a break from the day. It's a break from judgment. There's no one grading you at lunch. You get to relax, you get to be a kid, you get to have fun, hang out with your friends. One one of the most amazing things in school nutrition, and this is probably one of the top reasons I'm in this field, is that our staff is amazing. They love the kids, they know their names, and so they really make the kids feel seen and cared for, which is, I think, really important to their mental health. Um, I kind of got into this. Food and nutrition have kind of always been a passion of mine since, I don't know, probably high school. Um, and go, Going far back in my past, my grandmother was actually a dietitian. So
Wow.
the way my mother was raised and the way she was fed is the way she raised us, and the way, healthy eating is kind of ingrained in my family. Um, and then during my dietetic internship, I really just fell in love with school nutrition. A lot of it is the people. It's a way to make a difference in the world. It's a way to help, build a healthier future. Um, Specifically, I got into farm to school because I started to realize how little people, kids and adults both, know about our food systems. They don't know where their food comes from. They don't understand what a real carrot looks like. Which sounds a little crazy, but I have seen kids who they know what a cut carrot looks like. They know what a baby carrot looks like. But when you pull a carrot out of the ground, no idea. They don't know what a whole carrot is. Um, so I think part of my goal is just to help educate students about our local food systems, about agriculture, healthy eating, really making that connection between the farm and the plate.
That's so, I think being able to impact and influence the young is so important to be able to ingrain, a good foundation, good habits, being able to take their learnings, back home to educate, their families
Mhm.
um, so it's wonderful that we have these programs, and we'll dive into it a little bit, further for the young, and being able to shape a different future because, I think what has happened over really the last 20 years is we've come numb, to where our food is coming from, and we don't really understand it, and we're reliant, on what's through, in the aisles, at the grocery store, and usually those aisles are um, filled with processed, type food that are leading to chronic disease, and so really having an understanding of where things are coming from are really important, and so I want to start with really the seed to preparation components, of this journey, and love for Roberto to talk through further that transition you went through from, a leading institution at MIT, to being able to get your hands dirty, with soil, and what are the challenges and opportunities to be able to build, this system that you've created, and to be able to support economic vitality and community health. And if you can dig into that a little bit, further, because it's one thing to grow, there's another thing to be able to connect the dots, within the community and with different partners. And so love for you to kind of walk through how you actually did that, and some of the opportunities that it's presenting themselves, but also challenges to be able to continue to grow.
Yeah, yeah, definitely. I think for us, it really starts with that awareness of that food can heal, because I've experienced it. My staff and my team have experienced it. That's one of the main drivers of our work. And so it creates for us an intentionality for health. And it's one of the main reasons why we focused on microgreens and mushrooms to really kind of zero in on the first and foremost the anti-inflammatory effects of these very small but so powerful food items. And I didn't really know too much about microgreens or mushrooms before I actually started growing them. And so being able to understand that there's simple ways to grow food that can have a profound impact on your health really made us think about how can this be a solution to our food system, to our communities that are experiencing a lot of issues. And one of the beautiful things about these two products is that they don't require a ton of resources. We were just starting out, and when you're first coming into agriculture, like the odds are against you, especially if you have student loan debt. No one's going to loan you money to start a farm because the perception is that you are cash poor and you might be asset rich if you're lucky. So it's not a very glamorous, profession to get into, but there was something deeper for us that was driving it. And thankfully, through the support of my family and my business partner, we were able to acquire a property in Bennett, Colorado that we've been building ever since. And it's been such a long, slow process, but so rewarding in understanding it more as a lab, as a way to try different ways of growing food in an area that increasingly experiences droughts and high winds and just very extreme climactic changes, right? So we wanted to build a model of growing food that was resilient and that can buffer temperature changes in the wintertime and in the summertime. And so for us, it really kind of brought to focus not only how nutritious microgreens and mushrooms were, but how appropriate they are for the context of our farm. And that really opened the door for a lot of the partnerships that we created early on with food access organizations and now building relationships with hospitals and clinics as this movement and awareness around food as medicine is taking hold in a way that is gravitating towards local production, is seeing social relationships as a driver in that healing process as well. And what you said, Kevin, it de-silos what we're all doing across the supply chain and in our community. So for us, it was really about that intentional awareness, and building the relationships really helped us get started. And now is sustaining the operations that we see as a way to scale the impact and the distribution of food. So where we want to take this is really how we can co-design what we grow with community and dietitians in mind, so we can be even more specific around the types of foods that are appropriate for our context, that our community sees as familiar, accessible, and nutrient dense.
It's awesome. And I know you have, relationships, with schools and specifically Carlin and her school district. Carlin, can you talk a little bit further about how that maybe happened and, really the why and the outcome of being able to establish those local relationships and how does it translate into, the education and nutrition intake for the kids?
Yeah, so school nutrition is changing. Trends are less about how can we feed kids most cost effectively, and it is much moving towards how can we feed them, what's the word I'm looking for, more purposely. So how can we have healthier meals? How do we have more scratch cooking? How do we show kids more whole foods so that they understand, what these items are? And farm to school is part of that. It's been kind of a growing trend. I mean, nationwide, I would say over probably the last decade, pretty slowly growing. But then in the last 5 or so years, it's picked up steam quite a bit. And so it's just another step towards how do we make our kids more aware of what they're eating, and how do we um, provide them with healthy foods. So specifically, we came across Hardy Provisions. So I've been in my current role a little over a year. Prior to that, I was in different school district, and that's actually where I started working with Hardy Provisions. And it was largely, honestly, due to some grant funding. The state had a grant that was allowing school districts to buy local foods and then essentially be reimbursed for those items. And so, yeah, I mean, that's really how it got started. Local foods tend to be more expensive, and depending on the district you're working in, there's more or less money there. It's
Okay.
a bit complicated. I
Yeah.
won't get into the whole thing, but they're just, the funding is different district to district, and the way they're run is different district to district. Not really a right or wrong way, but that funding was instrumental, I think, in getting local foods really off the ground in Colorado.
Okay. And I will get into, some of the policy and the drivers, to some of this, maybe a little bit, later. But, I think these types of partnerships in local communities are so important to be able to obtain, measure, and then being able to grow, in the future. But, some of this is not about just getting the right food in front of people or the right produce. Some of this is about the relevancy, relative to the culture that you're feeding and the identity that of how food is sourced and prepared and accepted. And I know, Matt, you spent a lot of time, in this, and it's really a big mission, of what you're doing. Could you talk a little bit further about that and kind of the importance and kind of why you focused, on that?
Definitely, thank you. Yeah, and Roberto touched on it a touch, but culture and identity shapes every aspect of food, right? How it's grown, how it's received in the community, how it's prepared, all creates this, I guess, this relationship of trust, right? And so when we're looking at providing food into communities, if the food is not representative of the community that you're bringing food into, all of a sudden it feels like you're imposing this onto these community members. And there's not going to be that trust. There's not going to be that building of, okay, I see that this is something that I have to now adopt into my lifestyle, right? They're not going to be on that initial step to making this change. And so when we're looking at going into a community and helping provide meals, the first step that we look at is how can we listen of what the community needs? What are their tribal ingredients, their foods that we can build, meals around that fit whatever illness that we're trying to help solve for within that community, and making sure that that food is representative, making sure that the individuals have a voice in the meals that are created, right? And all of a sudden, now we're getting buy-in from the community at large, and now we're able to again extend how do we now work with the producers in the community, right, to close the economic loop there, to now get mutton from Dene for serving the Dene population, right? Look at squashes and corns, and then build those meals with ingredients that are familiar, that are eaten every day, that are traditional. And that starts really now building that trust. People feel seen, people feel affirmed, they're committed, and they start on that journey of saying, okay, I can actually get on board with this. And I think that's extremely important.
And I would imagine as part of that trust, there's greater adoption or sustainability, around that. And I think that is critically important on the clinical, side, of things, as, clinician myself, and maybe Carrie can dig into this a little bit further on some of the statistics, but we don't get trained, in nutrition, I think it's like an hour or two maybe in training, but zero, around the culture components, of this. And so if you're throwing food in front of people with, let's say, underlying congestive heart failure or underlying diabetes, and that's not relevant, to them, you're not going to be able to change, those behaviors, on those patients and to be able to positively impact their chronic disease. And so, Carrie, can you touch on a little bit, of that and, where you've seen people fail, in your with your clinical colleagues and where you've maybe, learned and thrived, in front of patients to be able to adopt, based on where that patient is from and where you're going to see the biggest impact, in sustaining, a new nutritional program moving forward.
Yeah, thank you for that. That's a great question. For me as a clinician, I got 3 hours of nutrition during my training. Most medical providers, research shows, gets less than 10, yet patients go to them thinking they're experts and ultimately what they say is gospel. So I actually just did a continuing medical education course that I taught for physicians, family physicians about nutrition, and it was really more about practically practically communicating nutrition to your patient. And my company, what's something really important for us is what we've created something called the renewed plate. So the idea is let's see first like what's on your current plate and then ultimately how can you adjust it. So rather than taking away someone's rice, you can look and see, and this is how like we're using technology like a continuous glucose monitor, for instance, to see when you eat this food, what is ultimately the impact it has on your body, and then how can we make a small tweak to get kind of that understanding of, okay, wow, this is something that really your body doesn't like, but you enjoy. So let's find a way for you to be able to continue to eat it. So we created this system, kind of the red, yellow, green plate, and the idea is that, and I was going to share my screen and show you if that's okay. I think that would be 1 second. But it was, I'll see if I can find it in a second. But it's a checklist. Oh, here it is. Basically, let's see. Hold on 1 second, sorry. But basically what I found is that for patients, when you tell them they can't have something, it feels like you're completely, especially for culturally, like if you take away rice from a patient and that's what they love, or now suddenly they go to a party and they can't participate, it feels really really frustrating. So our idea of like creating this red, yellow, green system where you learn ultimately to identify what is a red plate, what is a yellow plate, what is a green, and then ultimately how do you level up and transform just by swapping something out for one of the quadrants on the plate, a red plate to a yellow. And then the idea of like the 80-20 rule where you can have 3 red plates a week and enjoy it. So something that's good, for instance, for rice, if someone really likes rice and they want to eat it, they can actually put it in their refrigerator and then it creates resistant starch. And then the next time they eat it, it will be more like more fibrous. So your body's not going to absorb all the glucose from it, even if you reheat it. And it's not going to be spiking your blood glucose as much. So it's like that's a nice trick to make it so people can enjoy the rice. So I think as clinicians, our biggest challenge is that we don't have that training. And because of that, it's very hard to prescribe food, so we don't.
Yeah. And, just putting on myself as a patient, and trying to change my own behaviors, it is incredibly hard. And part of that is just society and really not knowing, but it's very complicated, as to what am I getting from a macro and micronutrient, standpoint, and how is it impacting, my health and well-being. Um, I would love to, for Matt to be able to touch on, as a restaurant and someone that prepares, meals for consumers, why you chose to look at preparing medically tailored meals. What was the business opportunity to be able to do that? There's been, a lot of work nationally around this and studying the impact of medically tailored meals. And one study will come out very favorable around it. Another study kind of, mixed results. Some states are paying for it, some states aren't. Why did you choose to, go down this path, with medically tailored meals, and what does the future look like in your eyes, with that kind of product or service?
Yeah, thank you. Yeah, it's a great question. It's definitely building the airplane as we all fly throughout this. I think some of the challenges as you're starting to see in some of the studies is like, what is a dosing of medically tailored meal, right? It hasn't yet figured out. How long does someone need to eat meals, right? From a time standpoint to reduce hospitalization. For us, when we've been working with Native communities across the United States, we see the challenges. There's more and more access to food, but the food isn't, in a sense, designed in a way that can easily be consumed.
Mm.
And so when we are looking at food, like, it's great to give people food, but if they are struggling because they're time constraint or they're busy, right, they're going to have a hard time. And so over the last 17 years of preparing food for people, we looked at how can we still put all the cultural relevancy, the stories, the identity in the meal, using traditional ingredients for the communities that we're working with, and put it in a format. And so we created a native frozen ready meal, and that can meet different guidelines and parameters, whether it's focusing on reducing gestational diabetes, hypertension, diabetes, heart healthy meals, and looking at, okay, so if we can work with these communities and build meals that serve the communities, and they're in the format that allows the user to consume it on their time frame based off of the care that they're getting, there's a better chance, if that meal is culturally relevant in a format that's easily able to be consumed, right? And it's not just made on a time frame that, well, if they didn't get a chance to cook the vegetables that week, those vegetables may, expire, right? And so we were really focusing on as we're working with these communities, how can we create that delivery format that allows, clinics to then house a bunch of frozen meals, right? And hopefully then by coming to your appointment, you can get a week's worth of frozen meals, right? And start creating buy-in. And what we've seen, within the short time of work that we've been doing in this space is, there's cultural connectiveness, right? There is a huge buy-in just from an identity standpoint. The fact that, people in rural areas where food access is hard, even though they may have the land, if there's not a market, and Roberto can speak on this, if there's not a market for you to sell your produce or your meat, you're not going to do that. And so all of a sudden, rural access to food security is a significant issue. And so, we also saw this as a way of making people more food secure in these meals. And from a business standpoint, I think it's challenging because, let's be honest, everyone wants to feed people until they have to pay for it.
Yeah.
Right. And we don't value our food, even though we have to consume it every single day.
Yeah.
And so I think the relationship to recalibrate and to value the people that plant, pick, butcher, harvest, distribute, prepare, and then consume it. That's something that we have to look at how we're going to value it, because it's going to take a lot of private public partnerships. We have to look at the payers and understand that payers are going to have to really look at being proactive, right, in investment into food, because, you know, their risk or their job is to manage risk on all different levels, whether it's patient or their financial risk exposure, right? And so by
Yep.
investing into the food system, by investing into meals, by investing into understanding the population that they're serving, it's going to change that relationship of how we value. See, Carrie, you want to jump in here?
No, I had a question for you just with the medically tailored meals. What different diagnoses are you seeing that are able to get this covered, and which ones are it's a struggle still for insurance to cover it?
Yeah, so I mean, as 115 waivers are starting to be stood up, like New Mexico State is, I think in July they're looking at two programs. They're looking at uh, gestational diabetes, and then they're also looking at in-home elder care around it. I think one of the things that we've found right now is that we have been working with private organizations that see a need, right? That say, well, this community that
Willing to
we've
pay.
seen is significantly struggling with, you name it. And how can we work to provide access to food? How can we work to start combating some of these health related diet illnesses? And so that's how we've been working through it. But it's a struggle when the reality is, if you're not paying fair for the food, right, it's really hard. And then as a consumer, you're telling me, and Carlin sees this, you're telling me I can only feed a student for $1 a day and barely get reimbursed.
Yeah.
Like people want to eat valuable food. People don't want to eat food that they feel like they're just been a handout. They want to eat the same food that someone else would eat. And so, that's been, I think, that's part of, one of the challenges that, we, as this gets stood up and we start to figure out the framework around food as medicine, that, everyone's going to have to come to probably some level of reality. You're not going to be able to squeeze every last penny out of this, or it'll never be resilient.
Yeah, I think it really has to, it is about, the big question in the US healthcare system, of paying for, in our fee for service world, paying for chronic disease and paying less in healthcare prevention. And I think this is where, our pediatric or our youth, and being able to invest in our youth before chronic disease occurs, and be able to change behaviors early on, is so important. And I'd love for Carlin to kind of talk on, um, what has there been communities, you said there's been a change or some movement happening over the last 5 years, where communities, or maybe it's parents, being able to advocate for better food access in schools. And maybe budgets are tight, but they're willing to be able to invest in this, with the whole idea around, um, feeding our children will allow for better, education, and will allow for, decreased chances of childhood obesity, or, being able to, decrease the chances of chronic disease setting in, early on. Can you talk a little bit further about that? And I'd love for Roberto to maybe like chime in around, maybe some policy or partnership structures that you find that are working, with those entities, whether it be schools, whether it be hospitals, that, in terms of why people are looking towards these partnerships right now.
Yeah, so there is kind of a shift in nutrition and looking more at disease prevention. So a little bit of a history lesson here. School nutrition actually came about because in World War II, there were so many soldiers that were being rejected from military service because they were malnourished. And so for a very long time, school nutrition was very focused on simply feeding And what was that, 2012, when Healthy Hunger Free Kids was signed into law. That's kind of what was signed in 2010, started implementation in 2012. But that's a lot of, some of the shift had been happening before that, 100%. But that forced a lot of it. And so funding does become a problem. And part of my role in Aurora, at least, is finding funding for us so that we can do some of the extra programs that we do. We try to give our community as much food and as much support as we can, whether it's in school, whether it's during summer, whether it's, you know, after school. And it becomes tricky because working off of grants is not necessarily a sustainable model, because you may not get the same funding year after year.
Yeah. Yep.
And so it's an interesting political climate at the moment, and I won't go into that, but it would be great if more people saw schools as part of the solution and saw school nutrition as part of the solution, and did provide us with stable funding that would allow us to really do what we can.
Yeah. And Roberta, why you've been successful at being able to have these relationships?
Yeah. I mean, when we started doing a lot of food distribution at volume, at scale, it was mainly to food access organizations that had funding to address the spike in food insecurity during COVID. And it worked so well, and we saw what that community-driven, equity-focused, resilient food system looks like. So my team really started thinking about, like, how come institutions are not participating in this? How come they're not part of this solution and this vision? And we tried to do some early outreach to schools and just found it to be a very cumbersome institutional kind of landscape to navigate. But it wasn't until LFS, the Local Food for Schools funding, came in that reimbursed schools for local purchases, that really opened the doorway to bring in that incredible bounty of local food that Carlin was talking about. So that helped us build incredible relationships, and a lot of the school districts that we now contract with through the state bidding system really kind of came out of that experience with LFS, seeing the possibility that this was possible, that this was something that we could actually do. And so that was a USDA program that was just now terminated in the early 2025. But Colorado stepping up to the plate, because now we have Healthy School Meals for All, HSMA, that's I think it's HB 1274, that the state now is in the perfect position to help maintain those relationships and that funding, specifically with the local food program. That's part of this package. And that's going to reimburse also schools for purchasing Colorado grown products. So it's these types of funding. Carlin's correct. Like, we need that just to kind of get to that first step. But it's really up to us, right, as community agents, as institutional anchors, to figure out sustainable ways and to understand creatively the economics to make this work. What's really fascinating is, you know, we have this backdrop of the potential impacts of the tariffs that we're seeing, especially on produce that's going to be imported. Well, we also have incredible partners here that if we align on committed buyers, they're going to be willing to work with us. That's going to build local food resilience, not just for the immediate term, but for future generations, right? And then also funding, for example, with the Local Food Purchasing Cooperative Agreement, which is also a USDA program that was discontinued. That was direct payments to local farmers to feed communities through intermediary food access organizations and food pantries. That helped a lot of farms scale up and really meet the need beyond that for the rest of the community in Colorado. And we also have WIC and SNAP patients that can participate in double up food bucks, right? Another policy that is in uncertain terms in terms of its longevity and the amount of funding to support that. But that is where we're looking at community partnerships. So, for example, we're looking at a potential opportunity with a clinic in Boulder to do prescription food boxes. There are similar types of programs happening in small pilots to see how we can actually scale and implement a sustainable way to keep these going. And farmers markets are also coming into the mix to try and figure out ways of addressing food access and nutrition security. But I think the policies that we need is how do we bring the farmer closer to the institution? How do we fund infrastructure in local food systems, right? And really fund farmers like frontline workers, because essentially we're also providing medicine.
Yep.
So it's a reconceptualization and reimagining of our relationship to food, to policy, to equity, and to health.
Yep. I think what's interesting, and Carlin, I don't know if you said the military passed that because of malnutrition. Is that what you said? That
Mhm.
um,
Yeah, pretty
now
much.
the statistic is like the direct opposite, where people don't qualify for the armed forces because we're over nourished, meaning obesity is so high because of not having the right foods. And I think it's maybe 60 to 70% of individuals that are at a particular age that wouldn't qualify in the military based on obesity, because we're not giving them really the right foundation and the right macro and micronutrients to be able to thrive, as kids. And so it's like this completely, opposite, issue that we have at this stage. And so it's like reversing course to what Roberto's, talking about, and the importance around bringing the farmer closer, to, the community, and to be able to feed, our community, further. And Don Berwick, who is, and I'll get to you, Karen. He's the founder of the Triple Aim from the Institute of Healthcare Improvement. He talks about the role of health systems and being able to provide, the role of a farmer, or the role of nutrition, within their doors, and to be able to feed their population, not only within their buildings, but also within the community. So, Kara, I'd love for you to comment, but also, as a clinician, I think about this all the time, and we're kind of closing out within 5 minutes, but talk about what you think in the future, what a farm to table to clinic model could really look like if you had everything aligned, whether it be the right stakeholders, the right payment mechanisms, and how it would, potentially translate into health and well-being, of communities.
So honestly, where I see the biggest barrier is that no one really knows how to cook what's given to them. And it's much easier to, like, I love the idea with the medical nutrition meals because they're ready to go. The majority of patients, I love the idea too of food prescriptions where they can get vegetables and things of that nature. But where I see the biggest barrier ultimately with the bringing the vegetables and everything into the clinic and distributing them is people don't really understand how to actually optimize or use these ingredients. So for instance, I received this box. I'll just show you really quick and then I'm done here. But where it was called the Kind Box. And the idea was that they give you a box of all kinds of different ingredients, and then you kind of have to figure out ultimately what to do with it. So I went through it and I actually ultimately created oops, wrong thing. I created here's how you take all of these ingredients and ultimately use every single thing. So I think then kind of looking at like, here's how you could do deviled eggs and, like how do you take all of these from your box and do that? So I think in order to have success, patients don't just need to know what the destination is, but they really need the roadmap.
That's awesome. And maybe to close out in the next 3 minutes, if you know, you could wave, each one of you could wave a magic wand, you know, for this, you know, farm to table to clinic to be successful, what would you need, you know, for this to be successful and to be able to change, you know, the health and well-being, you know, of our local communities? And we'll just kind of rapid fire in, you know, 30 seconds or less for each person.
I
I'll go
think the
first.
ability to see, oh, sorry. I think the ability to see the outcomes and track those.
Carla?
I was just going to say, I think Roberto hit the nail on the head, bringing the farmer closer to the community. There's a gap there, and I think that's a huge, huge opportunity.
Roberta?
Yeah, I would say, you know, incentivizing sourcing from local regional producers, however that might look, and finding ways to reimburse food as preventative care.
Yep. Matt?
Yeah, for myself, you know, touching on what Roberto said is understanding the value of food, recalibrating on it, and really knowing that, you know, to make this system really work, we can't just squeeze out every margin along the chain, and we really have to be proactive and invest in the system as a whole.
That's great. Well, I want to thank you all again, you know, for an amazing discussion, and hopefully this will spark, you know, listeners to be able to bring folks together more and sitting around a table together to be able to talk through ways that entities can really start to work together more, you know, from the farm or seed, you know, to the preparation, you know, to managing, you know, patients. And I think if we can do that in a scalable, repeatable way, we're going to be successful of changing the total cost, you know, of care, the outcomes, you know, of patient populations, and really the experience and the joy of our patients. So thank you, and I don't know if Sarah has some last words and to close us out.
Well, thank you all. I think in the absence of the ability to actually, I mean, since we actually did not get to be in person, I feel like in the absence of such, we should still share a round of applause. So
Look at that.
Your expertise, your information,
Fancy.
amazing. Had that teed up for you all. Thank you all. Your expertise is amazing. I know we had we had several questions in the chat. I know we didn't get to them all. Please keep asking them and keep attending our panels. Perhaps some of your questions will be answered in some of our future panels. So tomorrow we have a panel on medically tailored meals and prescription produce boxes, specifically with Project Angel Heart, MyFitFood, as well as Feeding Colorado. You can see the link to that in the chat right now. We hope you can join us. And again, thank you so much to the panelists. This was amazing. I learned so much. I hope everyone else did as well. And we will see you all tomorrow. Thank you very much.
Thank you.
Thanks, everyone.